Hello everyone. I am Dr. Prashant, and in this presentation we will talk about hepatorenal syndrome. Hepatorenal syndrome is a potential cause of acute kidney injury in patients with chronic liver disease. It can occur in cirrhosis, alcoholic hepatitis, and acute liver failure, and is a consequence of renal hypoperfusion due to splanchnic vasodilatation and renal vasoconstriction, as we will see later in this presentation. The diagnostic criteria for hepatorenal syndrome includes cirrhosis with ascites, serum creatinine more than 1.5 milligrams per deciliter, no improvement after IV fluids 1.5 liters, or diuretic withdrawal of more than 48 hours, absence of shock, ongoing infection, and absence of the use of nephrotoxic drugs. This is a schematic diagram of the liver and its surrounding structures. This is the splenic vein and this is the superior mesenteric vein. These two structures unite to form the portal vein. In a patient with cirrhosis of liver, there is increased resistance to flow of blood from the splenic as well as the superior mesenteric vein, and eventually there is increased pressure in the portal vein. Portal hypertension itself is described or defined as intrasinusoidal pressure of more than 6 millimeters of mercury. This condition results in various manifestations of portal hypertension such as splenomegaly and variceal bleed. This is a schematic diagram of the intestine along with its splanchnic vasculature. In patients with cirrhosis, there is vasodilatation of the splanchnic vasculature. When there is vasodilatation, the kidney interprets this as hypovolemia. Reflexively, to combat hypovolemia, the kidney now retains sodium and water and increases the antidiuretic hormone level. Its retention of sodium and water is due to the renin-angiotensin system. Now, the renal vasculature undergoes vasoconstriction in a bid to conserve its own blood supply. This vasoconstriction results in renal hypoperfusion, and this results in hepatorenal syndrome. We have to think of a few points before we move on to the clinical features of hepatorenal syndrome. As doctors, we must always keep in mind the possibility of spontaneous bacterial peritonitis in patients with cirrhosis and ascites. Also, diuretics, lactulose, angiotensin receptor blockers, and non-steroidal anti-inflammatory drugs should be discontinued immediately in patients with cirrhosis and ascites and evidence of renal dysfunction. Furthermore, due to cirrhosis, there can be a profound decrease in muscle mass in patients with cirrhosis, which may result in delay in the diagnosis of hepatorenal syndrome. Hepatorenal syndrome is classified into type 1, type 2, type 3, and type 4. Type 1 occurs when there is rapidly progressive renal dysfunction of a duration of less than 2 weeks with a serum creatinine of more than 2.5 milligrams per deciliter. Type 2 occurs in diuretic resistant ascites and in general has a creatinine of less than 2.5 milligrams per deciliter. Both type 1 and type 2 carry a mean survival rate of less than 6 months. Mortality is higher in type 1 as compared to type 2. Type 3 is in patients who have an additional chronic kidney disease along with the ascites and cirrhosis. Type 4 is hepatorenal syndrome developing in acute liver failure. The management of hepatorenal syndrome begins with prevention of HRS, and this can be done by avoiding intravascular volume depletion, judicious use of nephrotoxins or nephrotoxic drugs. Prompt diagnosis and treatment of infections, as already discussed, in the case of spontaneous bacterial peritonitis, we must initiate antibiotics immediately with injection cefotaxime 1 gram 3 times a day. The management of hepatorenal syndrome consists of measures to prevent bleeding, that is, we must give the patient beta blockers and band ligation. We can start pentoxifylline for severe alcoholic hepatitis. Corticosteroids are another consideration in alcoholic hepatitis, and the distinction can be difficult to make. However, in patients with a Madry's discriminant function of more than 32, in the absence of contraindications, both pentoxifylline and corticosteroids have found to be of similar efficacy. The treatment options may be either medical or surgical. We will now take a look at the medical treatment options. These include stoppage of all nephrotoxic agents such as ACE inhibitors, non-steroidal anti-inflammatory drugs, and diuretics. We should start the patient on albumin 1 gram per kg to a maximum of 100 grams per day till a target of 10 to 15 millimeters of water of central venous pressure. Along with albumin, terlipressin must always be administered. Terlipressin 1 milligram intravenous every 4th hourly, 3 times a day is a possibility. Midodrin and octreotide are another combination which is to be considered in patients with hepatorenal syndrome. 2.5 to 5 milligrams 3 times a day of midodrin to a maximum of 15 milligrams per day, and octreotide 100 microgram 3 times a day to a maximum of 200 micrograms TDS, that is octreotide. So in hepatorenal syndrome, we must consider one of these combinations, either albumin and terlipressin or midodrin and octreotide. Finally, if terlipressin is not available, then we can consider norepinephrine, and this is widely available in our ICUs at a dose of 0.1 to 0.7 microgram per kg per minute as an IV infusion, with a target mean arterial pressure of an increase by 10 millimeters of mercury. We'll now take a look at the surgical options in hepatorenal syndrome, and these generally consist of either a TIPS procedure, wherein we go back to our schematic diagram of the liver, and this is the inferior vena cava, and this is a transjugular intrahepatic portosystemic shunt or TIPS, which reduces the outflow obstruction, that is the obstruction caused due to cirrhosis, and frees up the direct channel between the portal vein and the inferior vena cava in this direction. Another surgical option is a peritoneovenous shunt, and in this is a schematic diagram of a peritoneum, and this is the internal jugular vein. When we connect the peritoneum to the internal jugular vein, ascites so produced is reinfused into the internal jugular vein. This is another option, although not used widely. Liver transplantation is the ultimate modality of treatment in hepatorenal syndrome and carries a 3-year survival rate lower for patients with hepatorenal syndrome than for patients without HRS, and the duration, degree, and severity of hepatorenal syndrome is an independent predictor of survival in HRS. Patients who require hemodialysis have a higher mortality rate. Other treatment options in hepatorenal syndrome include extracorporeal albumin dialysis with MARS, and dopamine and octreotide has also been tried. Non-selective endothelin receptor antagonists to inhibit renal vasoconstriction has been tried, but this has proved to be deleterious. And finally, misoprostol and N-acetylcysteine has shown no benefit in a recent trial. That's it for our presentation on hepatorenal syndrome. We would like to thank www.pexcells.com for great royalty-free images that we use in our presentation, and the YouTube channel Creative Venus, whose template we have used in one of our slides in this presentation. Thank you for watching, and we will see you in the next video.